Hello and welcome to Chapter 15, Communication and Documentation for the EMT. So in this lecture we're going to talk about communication systems and radio communication, the verbal report, interpersonal communication, and the pre-hospital care report, and then any kind of special documentation issues. So communication systems. We use various communication systems out there: radios, one-way pagers, cell phones, traditional telephones, landlines. Really, unless you're in a really rural area, then traditional telephones are kind of archaic, I guess. Cell phones, we get text pages on those cell phones. One-way pagers, again, not many EMS systems use them, but they are out there. And then, of course, radios. So the radio system consists of base stations, which are the radios that are like at a public service dispatch center, or they are at a station, and they're meant to be broadcast throughout the whole station or certain station, parts of the station. Mobile radios are what are in the vehicles, and allow us to talk to dispatch through the mobile radio. And then portable radios are the ones that we keep on our person. And then you have to have repeaters in certain areas. So like rural areas have repeaters, and that just basically what happens is that mobile radio or the portable radio or even the base station sometimes will go to that repeater, and then the repeater shoots it to where it needs to go, just as an amplifier basically. And then cell phones and telemetry. Okay, so this is the example of an EMS communication system. So we've got the EMS unit with the mobile, the mobile radio goes to the repeater, then it goes to the dispatch center. Again, the other way we have is a portable radio that goes to the repeater and then to the base station. So radio communications are regulated by the FCC. They assign licenses and to designated radio frequencies. They establish the rules regarding appropriate language and monitors radio traffic. So no cussing, no screaming, no cursing, no private information over the radio. So this is just a table of the principles of radio communication. The big one here is that you speak slowly and clearly. Courtesy is assumed, so there's no need to say please and thank you and you're welcome. We do it anyway. Yeah. So just roll through that. It should be in your book, and look at all of those things. So radio transmissions throughout the call. The initial call often comes in via telephone, but may be radioed from another agency. Without prompt and efficient dispatch and receipt of information, ambulances can be sent to the wrong location. And if two units transmit simultaneously, only one will be heard by listeners. We call it walking on them, and walking on the other person. So just be aware of that. Okay. So without prompt and efficient dispatch, they confirm the receipt of transmission by repeating part of it back. And dispatch may end the transmission with the time for documentation according to a 24-hour clock. So they'll say that what they want to say, and then they'll mark it with a time, because everything that is said over the radio is recorded by the dispatch center. So that way it's a legal document. It can be requested. So part of the reason that they confirm receipt of the transmission by repeating part of it back is so that way, just in case the radio, the recording didn't get the actual radio transmission that you sent out, it got what they said and repeated back. And then it also, they also mark it with the time. So carry the portable radio whenever you leave the unit, and radios need proper care and maintenance. Don't put them on the hood of the ambulance, because they will fall off the hood of the ambulance and get broken. Speaking from personal experience there. Report must be given to the destination hospital so that you can prepare for arrival. This is usually done by radio, structured to present only the most important information. Speak clearly and slowly. Do not give the patient's whole medical history over the radio. Just say, you know, the patient's age, their chief complaint, pertinent history, such as if they have a history of seizures, or if they have a history of having a heart attack or a stroke or something like that, because those are important things to know. Once we get into those chapters, you'll find out why those are important things to know. And speak clearly and slowly, okay? It's not a race. So, yeah. Okay. So when we give a medical radio report, you're going to want to identify your unit and the level of provider. Sometimes it's not necessarily necessary. We don't do it around here. It's not a common practice for us to identify the level of provider. You also want to give them your ETA, your estimated time of arrival, patient's age and sex, their chief complaint, brief, pertinent history of the present illness and injury, and any major past illnesses. Again, I wouldn't go too deep into the major past illnesses unless it's pertinent to their chief complaint or your diagnosis. Okay. Give a mental status, baseline vitals, any kind of pertinent findings of the physical exam, what kind of care you gave, if they responded to that care, and if you need to, you can contact medical control if you have a question. Okay. Communicating with medical directions. So give information clearly and accurately. After receiving an order or denial for medication or procedure, repeat back word for word. If the order is unclear, ask the physician to repeat it. And if the order seems inappropriate, question the physician. You are there on scene. If a physician gives you an order and you don't feel comfortable or confident, or you don't feel that it's appropriate, then don't do it. Okay. It's you are there with the patient. You know what the patient needs and how that patient is going to react to that procedure or order. Okay. So our verbal reports, these are given upon arrival at the destination. You're going to introduce your patient by name and give a complete and detailed report. So this is more than just the radio report. This is the verbal report. We're going to talk about the history of the patient. We may go a little bit deeper into it. We may, list out the medications that the patient takes. And then, the treatment that we gave en route, and vital signs. Okay. So interpersonal communication. Let's talk about team communication. The EMT must communicate with others involved in the patient's care. So first responders, fire department, PD, advanced EMTs and paramedics. So say you're a BLS crew, and you've called an ALS unit, you've got to be able to talk to the medic that's going to be there taking care of that patient. And then you've also got to be able to talk to the home health care aides and family. Speak candidly and respectfully. Don't put anybody down, and collect information about that patient. So communication techniques learned by experience may be more difficult with those in crisis. Everyone can improve their communication skills. I think being able to talk to people in the medical field and everything like that, it does come with experience. So use eye contact. It shows interest, comfort, and respect. Be aware of position and body language. Face the patient at eye level with arms down. There's some caveats to this, and it depends on the background of the person that you're talking to, because there are some cultures who think eye contact is a sign of disrespect, or a bad omen or something like that. So you've got to be aware of who you're talking to as well and their background. So therapeutic communication. We use language the patient can understand. Do not use medical terms. Various things that patients won't understand. Okay, so a patient's not going to understand that they are having a myocardial infarction in the left coronary artery. Okay, they're not going to understand that. They may get the gist of it, but they're not going to understand what it is. Okay, so that's where the term heart attack came in. The other issues with using medical terms, we don't want to use that jargon to make us sound smarter. Okay, all it does to your patient is make you look like a pretentious person. Okay, explain your procedures. Be honest. Dishonesty ruins confidence and rapport. Don't lie to your patients, but also be guarded with the information that you give the patient. Use the patient's proper name, Mr., Mrs., Miss. It's a sign of respect, especially with older patients. And listen. Listening is important to establish trust. Okay, we should be doing 80% of the listening and 20% talking when we engage with patients. And how we do that is by listening to them, giving them the open-ended questions, and allowing them to explain what's going on. Okay. So some special considerations. Always be compassionate and respectful of the patient. And be aware that they may have a mental disability. They may not understand completely what's going on. Be aware that some patients may have visual or hearing impairments. Do not assume that every older patient has a hearing impairment, okay? Or that they have any kind of language barrier. But be aware that that may be the case. In Hispanic families, typically the child will have to speak and be the translator for the family, because the older generations, the moms, the dads, the grandmas, can't speak English. So the younger generation will probably have to speak and translate. AT&T has an AT&T language line, so you can utilize that. And some bigger companies and bigger services will have their own language line that you can call. Google's great. You can Google, and because you can speak it into it. There's, I believe it's just Google Translator, but you can use Google to translate for you. Pediatric patients come down to their level and be truthful. They do not want you hovering over them. They see that as a sign of power and authority, and you want them to be open and honest with you, so get down on their level. So the pre-hospital care report, it's a written document of everything that happened during the call. There's several different forms of it. It can be handwritten. You can use a laptop, a tablet, or a pen-based computer. And then there's the transfer report. We don't necessarily have anything different. It's all a PCR, pre-hospital care report, patient care report. It's all the same for us. We use a laptop with a touch screen. We get signatures through that touch screen. So most services use some type of laptop or tablet. So the patient care record documents findings and treatment, conveys the picture of the scene, and it's entered into the patient's permanent medical record. It's a legal document. It can be subpoenaed and used as evidence. May help with patient win a case, and may be used against you in case of negligence. So administrative purposes, we use it for insurance information and billing. Okay. We also use these pre-hospital care reports for education and research. So clinical research, statistics, continuing education, and tracking the EMT's personal experience. Okay. Quality improvement. This is probably where like 80% of QI is based on, or training in a service is based on QI. So it's a routine call review, ensures compliance to standards, and can reveal providers deserving special recognition, and can also reveal opportunities for improvement. Data elements. So we talked about NHTSA. NHTSA, they have more than 400 elements, and a minimum data set is available nationwide. Okay, so run data, we have the agency name, the date, the times, the call number, various other things that is mandated to have, and the official time given by dispatch, so all times in report match. Okay. So then we have patient information, which includes the name, address, phone number, sex, age, and date of birth, weight, race, and or ethnicity, billing and insurance information. So information gathered during the call. So our general impression of the patient, narrative summary of the call, patient's prior aid, past medical history, physical exam results, vital signs, ECG results, treatments, medications administered, and any other information. Okay. So we have a narrative section, which includes objective information, which is the observable, measurable, or verifiable. And then there's the subjective information, subject to interpretation or opinion. Okay. The chief complaint, which is the primary complaint stated by the patient, and it's best recorded as a direct quote. The patient states that he feels like this. The patient states that his chest hurts. Okay. And then we want to record any kind of pertinent negatives. Avoid radio codes and non-standard abbreviations. Write legibly and use correct spelling. Information must be read easily and accurately. The patient care report is a reflection of your care. Use appropriate medical terminology, and if it's not written down, you didn't do it. So special documentation issues, legal issues, confidentiality, HIPAA, accountability and security, patient refusals. These are high liability refusals. They document all the details in a refusal of care form. You have to document. Okay, that's what it comes down to. Again, if you didn't document it, it didn't happen, and if it didn't happen, you don't document it. All right. Falsification, so covering up errors, recording something you forgot to do, correction of errors, mistakes in documentation, or additions. Okay, so you respond to a call for an unconscious male. Upon arrival, the patient is awake, alert, and walking away. He states that he was just sleeping and does not need or want treatment or transport. So is this a patient? Yes and no. I mean, we got called out there for a reason, so we do need to just make sure that he's okay. Is a complete assessment and physical exam needed? No, probably not. We just need to make sure that we document that he didn't have any like gross distress or anything like that. How will you document this call? So we'll attempt to get a PRC, that patient refusal of care. If he's unwilling to sign it, then you just document that he was unwilling to sign it, and do it that way. Should you obtain a formal patient refusal? You should try at least. Sometimes it doesn't happen. So again, document. So special situations, multiple casualty incidents, MCIs, okay. They can be a logistical problem for EMS in documenting, because there's so many patients, you know. It's also hard to figure out which patients you saw, which patients you didn't see, and by, you know, care and evaluation by several providers at different times and locations. So, I mean, document as much as you can. We all have those triage tags. The triage tag has everything, has the patient's name, their chief complaint, and whether they're tagged as like a green, yellow, black, red, various other things. So those do help, but just document what you can. So special situation reports, again, exposure to infectious diseases, injury to yourself or another EMT, hazardous or unsafe scenes, and referrals to social service agencies, and mandatory reports for child or elderly abuse. Each one of these is a special situation report, and typically you'll put it in your narrative or in your report that, you know, you had an exposure, or you referred the patient or family to a social service agency or something like that. So when that happens, then you'll just fill out those reports as well. So chapter review. When calling in patient information, we want to include these elements: the unit identification and level of provider, the estimated time of arrival, the patient's age and sex, their chief complaint, and a brief pertinent history of the present illness. Any major past illnesses, again, this is if they're pertinent to the current complaint. Mental status, baseline vitals, pertinent findings of the physical exam, and then emergency medical care given and the response to that care. We also want to, if we need to make contact with medical control, then do so. And then when we complete our PCRs, we want to make sure that we include the big things, like the patient's name, address, billing and insurance information, the nature of the call, the mechanism of injury, and the location. Okay. All of these things go into the PCR. Each service is different, and on what they require and don't require. I worked at a service where signatures weren't required, and we didn't get a signature. And then I switched to a service that did require signatures. So from the nurses especially. So it's just one of those things where each service is different in what they require and don't require. So a PCR may be a legal document in a court proceeding. The data from the PCRs helps to determine treatments, trends, research, quality improvement, things that we can improve on. You know, we look at our call volume. We look at how to space ambulances out and where those ambulances should be based on the number of calls that we have for that day in that area. So, I mean, there's lots of things that go into the PCRs. And your report should paint a picture of your patient and their condition accurately, describing your contact with the patient through the call. Okay, you have to be able to paint that picture in order to give somebody the idea that they are there and that they know exactly what's going on with that patient when somebody else is reading it. Okay. So things to remember: emergency medical communication comes in many forms and is essential to team-based patient care. The medical radio report is structured to present pertinent facts about the patient without providing more detail than necessary. The proper verbal report will include all of these things. Okay. Interpersonal communication is often challenging in EMS. Adopting best practices can improve communication capabilities significantly. Confidentiality, patient refusals, and falsification of records are all important legal concepts that you have to consider when documenting a call. Okay, so let's look at these questions. Again, no assignment, just look at them and think about how you would answer them. So how can you improve your interpersonal communication with patients and team members? What is the objective and subjective information in the narrative portion of the PCR? Okay. So organize this random information and present a radio report to the hospital. Okay. So chest pain radiating to the shoulder, 56 years old, oxygen applied at 15 liters per minute via non-rebreather, alert and oriented and female. Okay. Came on 20 minutes ago while mowing the lawn, has a history of high blood pressure. Sorry, I'm going to pull this up for just a second over here. Since I can't go backwards in this video. All right. So it came on 20 minutes ago while mowing the lawn. History of high blood pressure and diabetes. Patient has a pulse of 86. Respirations are 22. Skin is cool and moist. Blood pressure of 110/66 and SpO2 is 96. Okay. Oxygen delivered, relieved pain slightly, denies any difficulty breathing, and is requesting orders for, you are requesting orders for medical control. You're on a BLS, community BLS ambulance number 4. Lung sounds are equal on both sides, placed in position of comfort, and our ETA is 20 minutes. Okay. All right. So what would be the big thing here? Okay. So we're going to organize this information. So I am going to call into the hospital. Let's see. Community BLS ambulance 4 to Lake Regional Hospital, ER. They respond back to me, and I go into my radio report. I have a 56-year-old female with chest pain radiating to the shoulder. Came on 20 minutes ago while mowing the lawn. She denies any difficulty breathing. She is alert and oriented. Vitals are pulse of 86, respirations 22, skin is cool and moist. Her blood pressure is 110/66, and she is satin at 96% on 15 liters via non-rebreather. Pain is relieved slightly with oxygen, and I am requesting orders from Med Control, and I have an ETA of about 20 minutes. Okay, so I left out some stuff in there, but some of those things are not a necessity in the radio report. Remember, when you do the radio report, you want to be concise, clear, and short. Okay, there are other people who need to use that radio, and you don't have to lay out every single thing on that radio report. Whatever you don't get in your radio report, you can then use for your verbal report at the hospital and to put in your narrative. Okay. All right. So this is the end of chapter 15, communications and documentation. If you have any questions, leave them in the discussion post below. And as always, you can call me, text me, email me, and I'll answer those questions as well. So